Can you, are you able to hear me? Can I get an answer? Are you able to hear me all, students? We will wait for 2 more minutes. We will start at 7:10. Okay. Okay, we shall start now. So this is a test and discussion part for 50 questions. and all 50 are I have designed it like clinical case scenarios so that you will have a proper idea about all these conditions and when your NEET examinations come up. And all the best for your NEET examinations scheduled on May 5. And hope you all come out with flying colors. So without wasting time, I will go into the questions per se. These are actually initiate level questions are like you all know already that in initiate the pattern is like 20% is very difficult questions and 50 to 60% is moderately difficult questions and another 20% is all can answer type of question. So if you're supposedly you're looking at the statistics for every initiate examinations, you will roughly get around 10 to 11 questions per paper from biochemistry. So you can expect six questions to be very moderately difficult, and the two questions are extremely difficult, probably localizing around the genetics and molecular biology area. And another 20%, two questions can be very, very simple. Okay, so you need to have your basics very tight, and the concepts has to be very clear. If at all you need to crack any set. Okay, so it's not like NEET examination. The focus of high yield areas in NEET examination is vitamins and minerals, nutrition. That is the area where maximum questions are coming in NEET examinations. But then in any set examinations, the primary focus lies on the molecular biology and molecular biology techniques. Okay, so all these are very important if you're willing to get into IELTS, GMR, or PCI. Okay, so we will start with the questions. A 1-year-old female infant is brought by her parents to the emergency room with distress. Mother gave history of poor development of milestones. So this is the first history. 1-year-old is the first history, and the poor development of milestones is the second history. Infant's abdomen is tender and enlarged spleen and liver. So there is HSM present, hepatosplenomegaly present. Okay, so that is very important. There is a third point. After short course of treatment, the infant dies, and autopsy of neural tissue. Neural tissue is affected. Central nervous system is affected. Is fourth point. Shows parallel striations of electron dense material, zebra bodies. So zebra body inclusion bodies is the fifth point. Within lysosomes. So within lysosomes means it is a lysosomal storage disorder. It is a lysosomal storage disorder. Which of the following is the most likely defect present in this infant? Degradation of glucocerebrocytes, that is Gaucher's. Okay, so Gaucher's is the first option. Golgi associated phosphate transport to mannose is in Isel disease. So mannose phosphate is a tag which is attached to the protein targeted towards lysosome. So defective phosphate transfer to mannose, that is mannose 6 phosphate formation, is an inclusion cell disease. Degradation of ganglioside GM2 is Tay-Sachs. GM2 gangliosidosis comes under Tay-Sachs. And degradation of sphingomyelinase deficiency is Niemann-Pick. Now, if you look at this particular clinical history, you have to take one on point to exclude one on disease. Okay. Number one, Gaucher's. In Gaucher's disease, the most characteristic appearance is crumpled tissue paper appearance. Crumpled tissue paper. I'll come here. Gaucher, it is crumpled tissue paper appearance. That is the inclusion body there in histiocytes. So, and the most common is bone deformities, long bone erosions, localizing like Erlenmeyer flask deformities, and there is also a possible history of increased phytotriasidase or angiotensin converting enzyme activity. Okay, so nothing of this sort is given here. So Gaucher's is ruled out. The first option is gone. Okay, second, HSM is present in history. You must remember that Tay-Sachs is the only disease in which there is no hepatosplenomegaly. So Tay-Sachs, that the clinical features is H plus H minus H. So H is hyperacusis. There is a characteristic history of startling. Okay, the babies startle because they can hear more sound, and then there is hypotonia, the muscle flaccidity, without hepatosplenomegaly, minus HFM. So the main difference between the two GM2 gangliosidosis, the two GM2 gangliosidosis, Tay-Sachs, which is hexosaminidase A deficiency, and then there is hexosaminidase B deficiency, which is called as Sandorf's disease. So there is hepatosplenomegaly present in Sandorf. There is no hepatosplenomegaly present in Tay Sachs. This was a question which is asked in this NEET 2023. There was a clinical history in which they told that there is no hepatosplenomegaly in that baby, so that was Tay Sachs. Here, though, hepatosplenomegaly is present, so Tay Sachs is out, Gaucher's is out. Eisel disease, there is no problem in targeting. Okay, in Eisel disease, you don't see characteristic inclusion bodies like zebra bodies. Okay, zebra bodies are classically seen in Niemann-Pick disease. And the very classic feature of Niemann-Pick disease is a regression of milestones. That is what is given here for development of milestones. Okay, so all this is present, and Niemann-Pick disease can present with or without cherry red spots in macula. Even though the cherry red spots are not mentioned, so Niemann-Pick can present or without cherry red spots in the macula. So the characteristic in Niemann-Pick, there is three types: A, B, and C. Okay, this is more likely to be Niemann-Pick A type, and this is because of the enzyme deficiency sphingomyelinase. So that means the correct answer here is degradation of sphingomyelin, which is the Niemann-Pick disease. So the option D will be the correct answer as far as this question is concerned. So the first question is a clinical history, which is about Niemann-Pick disease. See, the questions are designed to give you maximum info about that particular topic, a particular disease, so that you will also remember about the other diseases. Okay, so the first question is over. The second question: 11-year-old boy met with RTA, undergone surgery for fractured femur. Post-operatively, severe hemorrhage requiring transfusion was seen. His PTT, APTT time is prolonged. The ICU team treated with normal plasma, after which his PTT returns to normal. The mode of inheritance of the boy's disease is similar to which of the following inherited enzyme deficiency? See, this is a question in which you have to know the basics about two diseases. The first thing is this boy has a prolonged PTT. Prolonged PTT is suggestive of hemophilia. And you all know that hemophilia, we have two types, hemophilia A and hemophilia B, which is chloric factor 8 deficiency. And the problem here is they are asking the mode of inheritance of the boy's disease. Hemophilia is an X-linked recessive disease. So you need to get this fact right. This is an X-linked recessive disease. Now they are asking you a very simple question. Which among the following is an X-linked deficiency, X-linked recessive disease? Adenosine deaminase deficiency, that is severe combined immunodeficiency, or glucocerebrosidase or Gaucher's. Hexosaminidase A is again Tay Sachs. Galactosidase A is Fabry's. Galactosidase B is Gravis. Galactosidase A is. So which among the following is an X-linked disorder? The only disease which is an X-linked disorder is Fabry's. So in order to know that among the metabolic disorders, you should know about the X-linked disorders. So let me tell you all the X-linked disorders in the metabolic diseases. In the carbohydrates, you have one X-linked disorder, carbohydrate medicine. It is Hunter's disease, which is a mucopolysaccharidosis type 2. That is an X-linked disorder. And in proteins, I'll go topic wise, that is a disease called as OTC deficiency. This is a urea cycle, second enzyme, ornithine transcarbamylase. Okay, that deficiency is an X-linked. And in lipids, the enzyme deficiency is Fabry's alpha galactosidase. So you need to know about all these things. These are the metabolic diseases which are X-linked. So in this particular question, the option which is X-linked disorder is Fabry's disease, which is option D. So you need to be very clear. You need to get your basics right to get this answer correctly. Number 3. A white man and a woman both are affected by an autosomal dominant disorder. They are heterozygotes. Heterozygotes, which means heterozygotes means there are two alleles. Okay. And one is a defective one. This is the okay. So this is a this is a so both of them are heterozygotes. And this is an autosomal dominant disorder. Okay. So autosomal dominant disorder, the word itself must tell you that there is a 50% chance of the offsprings getting that disease. When it is an autosomal recessive disorder, it is a 25% chance. See, there are only three things you should remember. Point number one, autosomal dominant, 50% chance of getting a disease. Autosomal recessive, 25% of getting a disease. Mitochondrial inheritance, 100% the disease will be inherited from the mother. These are the three things you should come to know when it comes to inheritance chances of diseases. Okay. So now they are telling there is an autosomal dominant disorder, and the disease was found to have 80% penetrance. Okay. The probability of producing phenotypically normal offspring is. Okay. The probability of producing phenotypically normal offspring is. See, now the point is usually there is a 50% chance of uh, uh, getting a what to say, the 50% chance of getting a disease. Okay. In 50% chance of getting a disease, this particular disease was found to have 80% penetrance. Okay, 80% penetrance. So not all of them will get the disease. 80% will get the disease. So what they mean is 80% of 50% will get the disease. So usual chance is 50%. 100% the gene is penetrant means 50%. That is, among the four children, two will get the disease. But the disease itself is only 80% penetrant. Okay. Which means that among the 50%, 80% will get the disease. So that means 80 by 100 into 50 will get the disease. Okay. So what it means is 40% will get the disease. So that is correctly what is given. So 40% will get the disease. So the answer here will be 40%. So 40% will get the disease and remaining 60% is will not get the disease. So what exactly you should know here is that penetrance. So penetrance is 80%, which means that the disease is not fully carried off, but the disease is actually penetrating only 80%. So 40% will be the answer. So most of the people have chosen this answer 50%. As such, autosomal dominant is 50%. But then when it comes to 80% penetrance, it is not like 50%. It is 80% of 50%, which is 40%. So that will be the answer. Okay. And then the fourth question. A 7-year-old boy with type 1 diabetes mellitus is brought to the emergency room in coma. He had an episode of flu 2 weeks before. On examination, his breathing is rapid with deep with fruity odor. All this means only one thing: he is suffering from diabetic ketoacidosis. His blood glucose is 46.5 millimoles. So it's very high blood glucose. He was administered with IV fluids, insulin, and potassium. The insulin stimulates which of the following rapidly? Okay. So the insulin stimulates which of the following rapidly means the insulin will cause what action? Which action of insulin is there? Okay. So that is exactly what they are asking. So insulin action, what are all the actions of insulin? That is what the main action of insulin is: glucose uptake via blood transporters. Okay. And that too, especially the blood transporter, which is under the control of insulin, is GLUT4. Okay. There are only three tissues which are under the GLUT4 influence. One is adipose tissue. The other is skeletal muscle. The third one is cardiac muscle. Okay. So these are the insulin dependent blood transporter for mediated tissues. Okay. If at all insulin is enhancing the uptake, they will go for only these three uptake of these three tissues. Okay. Fine. So what exactly are the options here? Fatty acid release from adipose tissues. Fatty acid release from adipose means this is lipolysis. Basically, insulin does not cause lipolysis. Insulin causes lipogenesis. So that is not the correct action. Ketone utilization in the brain. Ketone utilization in the brain, insulin does not promote ketone body synthesis. So there is no chances of ketone utilization. Glycogenolysis in liver. No, insulin inhibits glycogenolysis. Insulin inhibits glycogenolysis. So the only correct option is glucose transport in muscle. Okay, fine. So the correct answer here will be glucose transport in muscle. Let's move on to the fifth question. The fifth question. A 2-week-old infant was brought with complaints of intermittent episodes of vomiting, seizures, irritable cry, and hyperventilation. You have a doubt? They have asked phenotypically normal offspring. Which question is that? The probability of phenotypically normal offspring is 60%. Actually, 60% is not given in the answer. Probably they should have asked phenotypically abnormal only. The question is probably wrong. But then you get the concept here. They should ask phenotype. If it is a 60% answer is there, then they should go for 60% answer. But then your answer is this question is focused on 40% only. Okay. We'll just take this question again. But just get this concept. This is exactly the concept. 50% is autosomal dominant inheritance. 80% penitence means 80% will get the disease. Among the 50%, 80% is 40%. Okay. So this should be the concept. Just understand the concept. Okay. Fine. A 2-week-old infant was brought with complaints of intermittent episodes of vomiting, seizures, irritable cry, and hyperventilation. Okay. On examination, the infant was lethargic with distended abdomen. Blood investigations decreased citrulline and decreased blood. One means decreased urea. You can just have this as decreased urea. So with this data itself, you can just understand that it is a urea cycle disorder. Urea cycle. Which of the following clinical outcomes could be expected in this infant? See, it is very easy. What exactly you should know is there is decreased citrulline. They have told you there is decreased citrulline. So, which step forms the citrulline? Okay, and before that, whatever is there, it will accumulate. After that, whatever is there, it will not be produced. Okay, so whatever it is, you'll just look at into the options. We will go from the behind. Okay. Increased blood ammonia and increased urea in the urine, which is very wrong, because in urea cycle disorder, it is not increased urea, it is actually decreased urea, which means that we have just removed this. Okay. Decreased blood pH and uric acid crystals in urine. We are talking about urea cycle. There is no need for uric acid crystals in urine, so that is also wrong. Okay. And decreased blood pH and increased lactic acid in the blood. Where does lactate come from? Lactate comes in the carbohydrate metabolism. There is no need for lactate to come in this urea cycle disorder. Okay, so that is also wrong. The only thing that can be accumulated in urea cycle disorders is ammonia. Okay, it's not lactate, it's actually ammonia. Okay, so the remaining option is increased blood glutamine and increased orotic acid in urine. This will be the correct answer. How increased orotic acid means? See, the first step will be catalyzed by CPS1. Okay, the second step will be catalyzed by OTC. The probable defect in this zone is what is causing this above disease. When ornithine transcarbamylase is deficient, what will accumulate? CPS will accumulate. You all know that CPS can be broken down by CPS1 and CPS2. And CPS1 is in urea cycle, which happens in the mitochondria. CPS2 is in the pyrimidine synthesis. Pyrimidine synthesis. Okay. So this pyrimidine synthesis will lead to production of orotic acid. So you should remember, whenever there is an ornithine transcarbamylase deficiency, see, I have already told you two things. OTC is an X-linked disorder. I have told this. The second thing is OTC deficiency can cause increased orotic acid or orotic aciduria. That is because of the shunting of the CPS into the cytoplasm for pyrimidine synthesis. Okay. And then you should also remember this. This orotic aciduria is a refractory anemia. So it will cause an anemia which is not responding to vitamin B12 or folic acid, which is normally a megaloblastic anemia. But in megaloblastic anemia, usually you will suspect about vitamin B12 or folic acid, right? But if a megaloblastic anemia is there and it is not responding to vitamin B12 or folic acid, then you should go ahead and suspect orotic aciduria because it can cause a megaloblastic anemia. The third cause of megaloblastic anemia is orotic aciduria. Now, what about this blood glutamine? See, glutamine carries the ammonia groups. Okay, so basically, the first starting part of urea cycle is carbon dioxide plus ammonia. So the molecular formula of urea is NH2CONH2, in which there are two nitrogens and one carbon. The carbon comes from carbon dioxide, and the first nitrogen comes from ammonia or ammonium, which is from the glutamine, and the second nitrogen comes from aspartate. All these are asked in the aims previously. Okay, so all this should be remembered by you. So basically, there is increased glutamine, or there is increased ammonia, and there is a decreased urea in the urea cycle disorders. So you should remember all this, and the answer will be 5K. The answer will be 5K. Okay. Sixth question. A patient is suffering from cholera. See, this is the type of questions which have been asked in the INICET ever since 2021. That is last 2 years. Assertion and reasoning. Assertion is a statement which will be given. The reasoning is a probable reason for that particular statement. And if that particular statement is true or false, if that particular reason is true or false, and then if the reason is the correct explanation for that particular statement or not. All this is what is tested. It's a multiplex MCQ. You just have to find out which is correct, which is not correct, and if the explanation is the correct explanation for the statement. Okay. Assertion. A patient suffering from cholera loses fluids rich in Na plus, K plus, Cl minus in vomiting and diarrhea. Reason, cholera toxin causes ADP revascularization of Na plus Cl minus antiport of the GIT mucosa. See, the patient suffering from cholera loses fluid rich in. This is correct. And all of you will know that this cholera toxin causes ADP revascularization. It is correct up to that. But then the ADP revascularization is not about the Na plus Cl antiport. It is about the CGFP. It is about the CGFP. Okay. So ADP revascularization of that is only causes the loss of fluids. It is not about the Na plus Cl antiport of the GAT mucosa. So what is here is the statement is correct. So it means A is right, but then R is a wrong statement, or R is not a correct explanation. We will just see. A and R both are right, which means it is wrong. A as well as R are right. Wrong. A and R both are wrong, which is the only correct sensible answer. A is right, but R is a wrong statement. A is right, but R is a wrong statement. That is exactly what is the answer to be selected for this particular question, 6C. A 10-year-old boy reported to the hospital with chief complaint of inability in chewing caused by missing teeth. One. No, this is one. This is two. 10-year-old. He has delayed eruption of teeth. The family history revealed that the patient's paternal grandfather, highly flexible joints. So this is 3, this is 4. He had abnormally shaped head with wide depressed nasal bridge and skin. Okay, this is 5. And easily stretchable. So this is getting very clear. This is some kind of a collagen disorder. Okay. The hypermobility test score. Now the diagnosis is even more narrowing. Okay. Was above the normal range. What is the defective component and the diagnosis of given scenario? Fibrilin and Marfan disease. See, there are only 3 main extraconnective diseases. One is related to collagen, the disorders. The second is about fibrilin. In fibrilin, you have the Marfans and homocystinuria. And finally, it is about elastin. In elastin, you have pseudoxanthoma elasticum, alpha-1 antitrypsin deficiency, Williams syndrome. All these things are elastin-related disease. Okay. Now, the particular history says highly flexible joints. Okay. That is a very characteristic feature of a particular disease called as Ehlers-Danlos syndrome. Okay. Ehlers-Danlos syndrome, it has many types. There are more than 9 types, but then the most common types are Ehlers-Danlos 1. The most dangerous type is Ehlers-Danlos 3, which is a vascular disorder which can cause aortic rupture. Okay, but here this type collagen and Ehlers-Danlos syndrome. Here it is actually Ehlers-Danlos syndrome, which is involved in the type 5 collagen. Okay, so we are basically the most abundant type of collagen is type 1 collagen. Okay, but you should always also know about the other components which are mentioned in this particular question. Osteogenesis imperfecta. It is one of the most common disorders, but how to rule out osteogenesis imperfecta in this particular question means osteogenesis imperfecta means they will be giving you histories of repeated bone fractures, and there is also a history about blue color sclera and deafness. Okay, so all this must be present for osteogenesis imperfecta, and osteogenesis imperfecta has two types. One is called as the congenita, the other one is called as the tarta. OI congenita and OI tarta. Okay. There is no scope here for the vitamin C and scurvy because there is no petechial hemorrhages, there is no bruising or delayed wound healing, all those things. It's very easy. Marfanoid, lens dislocation, that kind of history is also missing. Bone fractures is missing. So this is missing, this is missing, this is missing. So here you should be very thorough about Ehlers-Danlos syndrome. In Ehlers-Danlos syndrome, you will always have a lot of what to say types. Okay, and type collagen most common is type 1, most abundant. Okay, type 4 collagen is involved in glomerular basement membrane. It is involved in a disease called as Alport syndrome. Type 1 is present mostly in the cornea, tendon, bones. Okay, type 2 is present in the vitreous humor, cartilage. Type 3 will be present in the space of disease, liver. Type 4 is in Alport syndrome. Okay, and then type 7 is very notorious because it is present in the skin. It leads to diseases like dermatopraxia. Okay, there's a disease called as dermatopraxia, and then there's blister formation diseases. All those things are involved in type 7 collagen. Okay, so you just have to know about all these things. Okay, type 9 collagen is there, type 10 collagen is there. Okay, all these things should be known. Other than this, collagen disorders can also be caused because of three things: copper deficiency, vitamin C deficiency. Okay, all these things can also cause, and the lathyrism. So Menkes disease, scurvy, and the lathyrism. These are the three other diseases which can cause collagen disorders. Okay, lysyl hydroxylase. Okay, lysyl oxidase, all those defects. This can cause collagen disorders. So basics about collagen disorders, everybody should know. This particular question is about Ehlers-Danlos syndrome. Which of the following is false regarding the cytogenetic technique? Which is the cytogenetic technique shown here? It's a color fish. It's a multicolored fish. Okay, fluorescent in situ hybridization. Can diagnose Cry-do-chat disease. Can diagnose Philadelphia chromosome. Can be used to detect molecular defects in cancer. Unknown chromosomal anomaly can be detected. This is a very tricky question because you will feel that everything is correct. What is there like that? But then you should know that fluorescent in situ hybridization, the technique itself means you should have a particular idea about what to look for. Okay, fish can detect aneuploidies. Fish can detect microdeletions. Fish can detect translocations. Okay, all this can be detected by fish. So all these things, see, everything will be covered. This is translocation, this is microdeletions, and it can also detect molecular defects in cancer. The problem is you should have a first-hand knowledge about what to look for. Okay, say for example, in Ewing sarcoma, there is a particular mutation which is happening, and that particular mutation is happening because and it results in the question of translocation from this chromosome to the 814, CML 922, something. All these things you should be knowing to be looking for that. So you need to design probes with that particular knowledge to look for that particular defect. If you do not have an idea, then you cannot design the probes. When you can't design the probes, that probe cannot go and point to that particular area and cause hybridization. Only when there is hybrid, see, first step is you design the probes. Second step, you send them in chromosomes. Okay. And then it binds to the chromosomal places. And then it hybridizes. Okay. And then it fluoresces. This is how it is done. When you have an idea about what to look for, only you can design the probes. When there is no idea, there is no probes. When there is no probes, there is no fish. Okay. So it cannot detect unknown chromosomal anomaly. It can only detect whatever is already known. It cannot detect unknown chromosomal anomaly. So this is a particular answer for this question. So this is unknown chromosomal anomalies cannot be detected. A 12-year-old boy presents with severe progressive skin ulceration, decreased immune response to infection, and impaired cognitive functions. He has been diagnosed with deficiency of enzyme prolidase. Okay. Mutation analysis reveals a single base substitution. So the first point is we have a substitution mutation at the 3' end of the intron. At the 3' end of the intron of the mutant allele and deletion of a 45 base exon in the prolidase. Now, there are two mutations here. One is an intron mutation, the other one is the exon mutation. Among these two, which is the significant one? We don't bother about introns. Okay. Introns are always spliced out. Okay. The only thing which we should bother is the deletion of a 45 base exon. Okay. Which of the following type of gene mutation was likely to be inherited by this boy? Okay, so missense mutation is a substitution mutation, but the substitution mutation is happening in the intron, which is not there. Okay. A 12-year-old boy, the boy has survived 12 years, which means that this mutation cannot be a lethal mutation. All of you know that both frame shift and nonsense mutations are lethal mutations. Okay, frame shift mutation is an insertion or deletion of a base. Insertion or deletion of a base. Okay, and nonsense mutation is a stop codon which is occurring and premature termination of the protein. Premature truncation or termination of the protein. So, missense mutation in the intron part which is not expressed, and a boy survives 12 years, which means that it is not a lethal mutation. So we can knock off frame shift mutation and nonsense mutation, which leaves us with only one choice, which is the splice site mutation. Now, this can even more augmented by the fact that they are actually speaking about an intron as well as an exon. So basically, the intron is there and then the exon is there. So the point of splicing, the mutation is somewhere here. That is why it's affecting both the introns as well as the exons. This is a very, very tricky question, but then you need to apply and then you should know the basics so that you can crack this particular question. Okay. A 3-month-old infant was brought by its parents with history of vomiting after being breastfed. So breastfed leading to vomiting, something related to milk. Okay. The episodes occurred frequently and caused weight loss in the infant. On examination, yellow discoloration of scales and skin, jaundice. Very nice. Clear picture of jaundice. Abdominal distension with increased frequency of stools. Mobility is increased. USG abdomen shows liver enlargement. Hepatomegaly is present. Characteristic cataract. See, by this time, you should make a diagnosis. This is a very straightforward question of galactosemia. And what is the enzyme which is defective in galactosemia? It is galactose 1-phosphate uridyl transferase. These are the questions which I told that there will be two questions which are very simple. You should not miss these questions. Galactokinase deficiency, no, that is galactosuria. And aldolazine fructose metabolism. Glucose 6-phosphatase defect is von Gierke disease, which is a glycogen storage disorder. So the answer here is galactose 1-phosphate uridyl transferase, and this is a classic picture of galactosemia. A middle-aged man diagnosed with A-beta lipoproteinemia found to have membrane abnormalities in erythrocytes. Okay, in erythrocytes there will be thorn-like features in A-beta lipoproteinemia. Okay, so he also had hyperkeratosis, very important feature, acrodermatitis and hypercholesterolemia. And the abnormal red cell morphology would most likely result from malabsorption of which? See, the point here is A beta lipoprotein. Okay, and then there is hypokeratosis. Okay, when there is A beta lipoproteinemia, there will be low LDL, VLDL, and TGs. Okay, low LDL, VLDL, and TGs. Okay, and also the RBCs are affected. The skin is affected. That is because we need fatty acids to form triglycerides. Do you know what is triglyceride made up of? It is made up of glycerol plus fatty acids. Okay, so and there is a deficiency of fatty acids. Okay, and there is a deficiency of acids. When there is a means when there is a deficiency of TGs, there is no fatty acid. So they are basically asking you which fatty acid is not absorbed properly, or they are asking you which is the fatty acid which is essential among all these things and is not properly absorbed. They're basically asking you about essential fatty acid deficiency in this question. And this hyperkeratosis is also a feature of a disease called as rhinoderma. That is why I marked this as an important point. Okay, so they are asking you which among these things is essential fatty acid. You all know that the essential fatty acid is linoleic acid. So ascorbic acid and folic acid are water soluble vitamins. Okay, there's even though ascorbic acid cannot be produced in the human body because of the deficiency of the enzyme L-gulonolactone oxidase, it is not a fatty acid. They are basically water soluble vitamins. We are dealing about fatty acids here. Linoleic acid is a only essential fatty acid. Arachidonic acid can be produced from linoleic acid. So that is not an essential fatty acid. So here the best answer would be malabsorption of the essential fatty acid, linoleic acid. Okay. Again, you should know two things. One is fatty acid is involved in A beta lipoproteinemia, TG, low TGs. Second thing is the essential fatty acid, which is the essential fatty acid, linoleic acid. A 4-year-old girl was brought to the family physician and her mother gives history of delayed walking in the child when compared to her elder brother at the age of 3 years. Serum calcium is normal, PO4 low, alkaline phosphatase is slightly increased. There is a bone deformity. X-ray studies revealed cupping of the distal radius and distal femur with widening of epiphysis, very classical feature, and angular deformities. What is your diagnosis? This is a 4-year-old girl. This is a very straightforward picture of a disease called as rickets. In children, it is called as rickets. In adults, it is called as osteomalacia. Okay, so which is the characteristic feature in rickets? See, here you cannot go ahead and put hypercalcemia, hyperphosphatemia. They are asking about a disease. Okay, it's either vitamin D deficiency, which is causing the rickets, or some people say that vitamin D toxicity. No, vitamin D toxicity is not like this. This is a classical feature of delayed walking in the child, which means that there is a defective bone. Okay. The other features like Harrison sulcus, the PG and chest deformities, they are all not mentioning that. They are just given you the cupping of distal radius and winding of the epiphysis, which is very much enough to seal the diagnosis as rickets. And rickets is nothing but vitamin D deficiency. You just need to know that this is a very important area when it comes to nutrition, vitamins, and minerals in INICET. Okay, INICET is more focused. See, the NEET exam is in, I don't know why. They are very much fantasized about pellagra. So much questions about pellagra in the last 2-3 years. But then the INICET examinations are more focused about vitamin D. Okay, so vitamin D deficiency, vitamin comes to stay is very much important when it comes to INICET. That's why I put this question out. Okay. A 60-year-old female was diagnosed to have type 2 DM. Her treatment regimen included diet, exercise, and oral medication, to which she has been intermittently adherent. She has been working on more and exercising less, and her last hospital visit was 15 months before, irregular follow-up. Which of the following complications is less likely to occur in her with type 2 diabetics as opposed to type 1? So they are just asking you, among these four, which is very typical of type 2, which is very typical of type 1 diabetes mellitus when compared to type 2 diabetes. See, weight gain, classic feature of type 2 diabetes mellitus. Retinopathy and cardiovascular disease are microvascular complications. Nephropathy, retinopathy, and cardiomyopathy. All these are microvascular complications of type 2 diabetes mellitus. But then type 2 diabetes mellitus is not much associated with hypoglycemic coma. Hypoglycemic coma is a very classical feature of type 1 diabetes mellitus. So it cannot be associated with type 2 diabetes mellitus. Type 2 diabetes mellitus usually that's because of type 1 diabetes mellitus is because of insulin deficiency, whereas type 2 diabetes mellitus is because of insulin resistance. Insulin resistance has very little chances of causing hypoglycemic coma when compared to insulin deficiency. So it's a very simple question only. What you need to know is hypoglycemic coma or hyperosmolar coma and diabetic ketoacidosis are particular features of type 1 diabetes mellitus, and they are not about type 2 diabetes mellitus. Okay. A 55-year-old obese female presents to the clinic with mild epigastric pain and vomiting after a fatty meal. Okay, so she had a fatty meal and she had mild epigastric pain and vomiting. She had similar episodes in the past. On examination, there's abdominal pain, and ultrasound revealed few gallstones in the gallbladder. Okay. Fertile, female, 40, fat. Okay, all these are predisposing factors for gallstones. Okay, fat, fertile, female of 40, who's fertile. Okay, all these things, fat, female, fertile, 40. A gallstone that blocked the upper part of the bile duct would cause increase in which of the following. Okay, so there is a blockage in the bile duct. Okay, what will happen? That is what they are asking. This is just blockage. Okay, number one, you should know that bile salts travel from through the bile duct into the duodenum, and these bile salts are involved in the emulsification process in forming the vessels. So when there's a block in the bile duct, there is no bile salts, there is no emulsification, so there is no digestion of lipids, which means that there is no formation of chylomicrons. Okay, and when the bile salts are not entering into the intestine, they cannot be recycled via the enterohepatic circulation. Okay, and when there is a blockage in the bile duct, how can the excretion of bile salts be increased? So that is also not possible. So when all this is happening, the fats are not digested. So all the fats are being excreted in the urine. This is called as steatorrhea. How diarrhea, diuretics means diarrhea. It's okay. That is like fluids are more. That's why diarrhea means it's just excreted. Fluids are excreted more in the stools. Steatorrhea means fats is excreted in the stools. So there is blockage. Blockage means bile salts cannot enter into the intestine. Bile salts are not there means no emulsification, no fat absorption. Fats are excreted into the feces. That is exactly what's happening. Okay. So the answer here is option C. A 6-month-old infant on synthetic formula feed started showing sugar in the blood and urine. The sugar compound gives a positive result for reducing sugar. So it's a reducing sugar positive, but was negative with glucose oxidase test. Glucose oxidase peroxidase. It is called as GOD-POD. It is a test to diagnose glucose. So now you have two facts in your hand. One, that urine is positive for reducing sugar. Glucose is a reducing sugar. Fructose is a reducing sugar. Maltose is a reducing sugar. Okay. Among these three, these are the reducing sugars. Sorbitol is an alcohol. It is not a reducing sugar. Now you have narrowed down our chances to 75%. Okay. One option is cut out. Now they are saying that this particular urine is not positive for GOD-POD, which means that it is not glucose. It is not glucose. Okay. And treatment of blood and urine with acid does not increase the amount of reducing sugar measured. Now, this is a very particular point. This is a test which is called as acid hydrolysis. Acid hydrolysis test is positive when there is sugars like maltose. See, acid will break down the maltose. So the maltose will be broken down to produce more sugar. So when there is a acid hydrolysis positive, which means that maltose is present. But they are telling treatment with acid does not increase the amount of reducing sugar, which means that the sugar is not broken down by acid, which means that it is not a disaccharide, it is just a monosaccharide. So among all the options, the only option which is left is fructose, which is a reducing sugar. It is positive reducing sugar. Number two, it is not positive for glucose oxidase peroxidase. Yes, that is also fitting. And number three, it is not broken down by acid hydrolysis test. So now you should know basic carbohydrate chemistry to answer this question. If you are very strong in your basic carbohydrate chemistry, then you will get this question very, very easily. So the answer here is fructose. Okay. Question number 16. A young man had recurring episodes of hyperlipidemia, proteinuria, and anemia. And fasting blood test revealed slightly elevated unesterified cholesterol. Very, very significant. See, cholesterol is there, and this cholesterol is converted to cholesterol esters. Okay. And this cholesterol is converted to cholesterol esters by two enzymes. The first enzyme is called as acetic ACAT. The second enzyme is lecithin cholesterol acetyltransferase, which is LCAT. Now, cholesterol is converted into cholesterol esters in the tissues by ACAT, and cholesterol is converted into cholesterol esters in the blood or plasma by LCAT. Okay, and then this cholesterol esters are handed over to the HDL. Okay, basic idea is the cholesterol esters occupy lesser space when compared to cholesterol. So the cholesterol esters go inside, whereas the free cholesterol stays outside whenever the lipoprotein is concerned. Okay, so this particular conversion of cholesterol to cholesterol ester facilitates the transfer of cholesterol esters in the exchange between HDL to VLDL and HDL to chylomite. So if you know the lipoprotein metabolism, HDL takes up cholesterol esters and triglycerides, triglycerides from the chylomicrons and VLDLs, and gives off cholesterol esters to the chylomicrons and VLDLs to be deposited in the liver. That is cholesterol, that is lipoprotein metabolism. So we'll not go into that, but then just remember that cholesterol to cholesterol ester conversion in the tissues is by ACAT and in the plasmids by FCAT. Now they are telling elevated unesterified cholesterol, which means that there is a block in this step, which means that ACAT and LCAT are basically deficient. Okay, ACAT and LCAT are basically deficient. Okay. The deficiency of which of the following proteins would result in the features seen in this patient? Okay. Now, you could very easily find out, I have explained to you, the answer is ACAT. Okay. So, now, the only thing you need to identify here is, you should read the question very clearly. You all, by reading superficially, you will come to the diagnosis that it is a ACAT deficiency. But then it is wrong. Why it is wrong means the patient is given a 200-gram chocolate bar and blood lipid levels are monitored hourly. You should know this word, blood lipid levels, showing significantly increased levels of unesterified cholesterol and phosphatidylcholine. So they are saying in blood, cholesterol ester formation is less. So they are not speaking about ACAT, but they are speaking about LCAT deficiency. And you should know that the factor which is needed to activate LCAT is ApoA1. ApoA1 is an activator of LCAT enzyme. So a deficiency of which of the following proteins would result in the feature seen in this patient is, it is ApoA1. So if you read superficially, you will select ACAT as answer. But then they are not speaking about the intracellular component. They are speaking about the extracellular component, which is the blood unesterified cholesterol. In blood, the action is done by LCAT. And for LCAT activity, we need to ApoA1 is the activator of LCAT. So which means that you should go ahead and find out the correct answer, which is ApoA1. Okay, you should not go with this answer. This is wrong. This is the correct answer, ApoA1. Okay. A 61-year-old man had a 2-week history of weakness, polyuria, intense thirst, and difficulty in speaking, and staggering walk and weight loss. He was on 2 lakh units of vitamin D for osteoarthritis for a short duration. His plasma calcium was 25. See, what has happened is he had OANE, he had difficulty. Someone prescribed him vitamin D, and that too 2 lakh units. It's a very straightforward case. And this vitamin D obviously increases calcium level. He has gone into very severe hypercalcemia. Okay, anything greater than 11 mg per deciliter is hypercalcemia. He's gone to 25 mg per deciliter. What's the most probable diagnosis? This is very, very simple, straightforward question. Vitamin D toxicity. The normal levels of vitamin D in humans is 30 to 100 nanograms per annum. Okay. Anything less than 30 but greater than 20 is mild deficiency. Less than 20 but greater than 10 is moderate deficiency. Less than 10 is very severe deficiency. In these cases, you will prescribe vitamin D 60,000 units once a week for 8 weeks. You can get this in capsules like D-Rice. All those capsules are the Shell Cal HD that comes with calcium and vitamin D. Okay, so just put them on once a week dosage for 8 weeks. Top it up with daily dose of calcium along with vitamin D. They'll be fine. But this particular man has taken 2 lakh units. Remember, how much ever you take water soluble vitamins, it will be excreted in the urine. But the fat soluble vitamins have a propensity to get deposited in the liver and it can go for toxicity. Fat soluble vitamins are a little bit dangerous when it comes to overdosing. Okay, so this is a category. See, I have also discussed you about vitamin deficiency. Now I have also given you a case about vitamin D toxicity. Okay. A 1-year-old child accidentally ingests a small portion of rat poison, very typical rat poison. While playing, the poison contains fluoroacetate, okay, fluoroacetate, which combines with oxaloacetate to form fluorocitrate. Which pathway is the most likely to be inhibited by this poison? Very simple. They are asking you fluoroacetate inhibits which pathway? Fluoroacetate is a competitive inhibitor of an enzyme called as aconitase. Aconitase is an enzyme in TCA cells. In TCA cycle, there are only 3 poisons. One is fluoroacetate. Number 2 is arsenite. It is not arsenate, it is arsenite, alpha ketoglutarate dehydrogenase. And then number 3 is malonate, which is inhibiting the succinate dehydrogenase. These are the 3 poisons of TCA cycle. I picked up this particular question because in AIMS 2019, there was one particular question. Fluoroacetate, they didn't ask like that. Fluoroacetate combines, a poison combines with oxaloacetate, condenses with oxaloacetate and prevents formation of citrate. Okay, what is that particular poison? There was a question like that. So that was asking fluoroacetate. Now I just inverted that question. I given you the fluoroacetate and I am asking you which cycle it is inhibiting. So this is a high yield area as far as AIMS and NEET is concerned. Answer here is TCA cycle. Okay. A 45 years old non-alcoholic is found semi-conscious at the garden, was admitted in the emergency room. Initial laboratory studies showed high anion gap. High anion gap means it is metabolic acidosis. In metabolic acidosis, it can be AGMA or NAGMA, very rarely LAGMA, okay, low anion gap. Okay, the blood alcohol was also high, heavily intoxicated, and his blood glucose was 40, hypoglycemia. Okay, so basically it is alcohol-induced hypoglycemia. The patient's high anion gap and hypoglycemia can be explained by which of the following. Now, if you see, when you take alcohol, this alcohol is acted by alcohol dehydrogenase and it is converted into acetic acid. Okay. Acetaldehyde. Acetaldehyde. And then it is converted again by an aldehyde dehydrogenase to acetic acid. This acetic acid can be converted into acetyl-CoA and this acetyl-CoA can go for ketone body synthesis. But in all these cases, there is NADH produced. So basically, alcohol increases NADH. Alcohol increases NADH-NAD ratio. And when this happens, increased NADH can cause conversion of pyruvate to lactate. And this lactate leads to acidosis. See, all this will happen. Okay. The point you need to understand is alcohol causes increased NADH. And this NADH is an allosteric inhibitor. Allosteric inhibitor of many TCA cycle enzymes. When TCA cycle is inhibited, acetyl-CoA is not converted into ATPs. So it means that more acetyl-CoA will be increased, which means that more ketone bodies will be synthesized. Okay, so that is basically a protective mechanism because hypoglycemia will occur. See, again, why hypoglycemia will occur means when there is increase in NADH, it will drive the glucose breakdown and it will inhibit gluconeogenesis. So that will lead to hypoglycemia. So hypoglycemia, brain should not collapse. So this hypoglycemia, this increase in NADH causes hypoglycemia, but also increases acetyl-CoA for the brain to function. See how beautifully it is all integrated. So now the answer here is inhibition of dehydrogenase enzymes by NADH. Alcohol functions by only one mechanism, increase the NADH-NAD ratio. That is exactly what you should take from this particular question. Okay. A 36-year-old woman visits the fitness center after seeing an ad of a new weight loss medication. The center claims that the drug causes burning of excess calories without doing exercise. Which of the following compounds in theory, just in theory, could make this happen? See, there are 40 anti-obesity drugs. Okay. But then everything has a side effect. Okay, all this is theoretical. Okay. Most commonly used being orlistat. Okay, orlistat is the most common see, orly means lipase inhibitor, lipase stat. Okay, that is orlistat. Okay. But then here they are asking about the electron transport chain components. Which of this can happen? Among the electron transport chain inhibitors, there is one group called as uncouplers, which uncouple the heat production and ATP generation or oxidative phosphorylation. So when there's uncouplers, there is no ATP generation, there is only heat production. ATP generation is important because ATP increases glucose synthesis. ATP increases triglyceride synthesis. ATP is used in purine, pyrimidine synthesis, biosynthesis of all. Okay. Now this TG synthesis will lead to increased weight. So when there is no ATP, you will start losing weight. You will go towards the emaciation. Okay. So that is basically the component. They are asking, is there a possibility that uncouplers can reduce weight? Yes, uncouplers can reduce weight. That is because uncouplers cut off ATP generation. They produce only heat. What are the uncouplers? There are physiological uncouplers called as thermogenin, brown adipose tissue. And then there are pathological uncouplers, which are 2,4-dinitropglycerol, 2,4-dinitrophenol. Okay. So these are the two pathological uncouplers. So now they are asking which is the uncoupler among the following four options. The uncoupler among the following four options is dinitrophenol. What is atractyloside? It is the ATP, ADP translocase. This is complex 1 inhibitor. This is complex 3 inhibitor. So the correct answer here is dinitrophenol. Assertion. Aldolase is an example of hydrolase class of enzyme. Aldolase cleaves the bond in the fructose 1,6-bisphosphate to form glyceraldehyde phosphate and dihydroxysulfone phosphate, and water is not required for this reaction. Now, in these two statements, aldolase cleaves the bond. This is a correct statement. So R is a right statement. Okay. But what about A? See, there is a problem here. A statement says it is a hydrolase, which means hydrolase requires water to break CC, CN, or CO bonds. Among these three bonds, if they are broken with water, it is called as a hydrolase. If it is broken without water, it is called as a lyase. Aldolase step is a breaking step. It does not require water, which means that aldolase is not a hydrolase. Aldolase comes under class 4 enzymes, which is a lyase. So, whichever statement says A is right is obviously wrong. So, A is right. A and both are right, wrong. A as well as R are right, wrong. Now, we have only two statements. A is wrong, but R is a right statement. A and R both are wrong. R is right, I told you. So, this is also wrong. So, the only correct answer is A is wrong, but R is a right statement. Now I mean that it's a right statement because it's not a reason, it's a right statement. So this is the correct answer as far as this particular question is concerned. What I want you to know is aldolase is a class 4 enzyme called as lipase. A 55-year-old female had repeated episodes of joint pain involving both knees and lower back. X-ray changes suggestive of rheumatoid arthritis, and orthopedician started methotrexate. So starting about DMARS. This is a modifying rheumatoid arthritis. After a few days of intake, the woman develops many side effects that are related to competitive enzyme inhibition. Okay, dihydrofolate reductase inhibitors, competitive enzyme inhibition. Okay, so when there is a competitive inhibition, what will happen? There is increased Km. Increased Km means decrease the affinity to the substrate. Okay. So her doctor gave additional folate supplements which can decrease the side effects. So you can increase the enzyme activity by increasing the substrate. That is what the doctor has done. He has given more folate. Okay. More folate to overcome the competitive inhibition. Okay. So which can decrease the side effects. So that is what, by without interfering with the efficacy of methotrexate. Thereby, patients taking methotrexate are given sufficient loads of folate. Okay, folate in the form of folinic acid. Which are the following most likely occur? Okay, which are the following will most likely? See, you should understand that this is a very important point. Decrease the side effects without interfering with the efficacy of methotrexate. So the methotrexate must act, but then the side effects only must disappear. Okay. If you see here, dihydrofolate reductase will have higher apparent Km for dihydrofolate. I told you Km will be increased. Okay. Now, who is Km increased? Km will be increased towards methotrexate. It will not be increased to dihydrofolate. Okay. It will not be increased because the affinity towards dihydrofolate will be increased. So, increased Km towards methotrexate and decreased Km or increased affinity towards dihydrofolate. You should be very clear. You should be very clear. Okay. So statement A and statement C, both are actually testing your knowledge on this particular question. Okay. See here. Dihydrofolate reductase will have a higher apparent Km for dihydrofolate. No. Dihydrofolate reductase will have a higher apparent Km for methotrexate. So this option is now, dihydrofolate reductase will increase its affinity for methotrexate. No, dihydrofolate reductase will increase its affinity towards the substrate. Which is a substrate? The substrate is dihydrofolate. So this statement is also wrong. Okay. So decreased Km or increased affinity towards decreased affinity or increased Km towards methotrexate and decreased Km or increased affinity towards dihydrofolate. Okay. This would be that, but both the statements are wrong. Now we are left only with B and D. Dihydrofolate reductase will have a higher Vmax than it would in the absence of methotrexate. Dihydrofolate reductase will reach the same Vmax as you would have in the absence of methotrexate. Now you should remember that in competitive inhibition, only Km is increased. Vmax remains the same. Vmax remains the same. So with or without the inhibitor, Vmax will remain the same. So the correct answer will be option D. Dihydrofolate reductase will reach the same Vmax as it would in the absence of methotrexate. See, Km increased, Vmax not changed. Everybody will know this. But then to apply this and get an answer out of this question, that is where application stands. That is where the INICET people are different from the normal people. Okay. A laboratory wants a rapid way to purify proteins which are targeted to lysosomes. So they are asking you about protein targeting. Question is about protein targeting. So they decided to use affinity chromatography. An appropriate antibody that can be used on an affinity chromatography column is directed against which of the following. So basically they're asking you which of the following is involved in protein targeting. See, the protein targeting has two pathways. Okay. Co-translational pathway, post-translational Okay, so proteins are basically targeted towards nucleus, mitochondria, lysosomes, Golgi bodies, endoplasmic reticulum, and of course peroxisomes. All these genes. The proteins are targeted by adding a pin code to that particular protein. The pin code is like this. How an address has a pin code, like that the proteins also have a tag marker. That particular marker is mannose 6-phosphate. And this mannose 6-phosphate is added to the proteins by an enzyme called as glutamate phosphotransferase. Glutamate phosphotransferase. Okay. So here they are asking you protein targeting, which of the component is involved in the component which is involved is mannose 6-phosphate. So if you come out with an antibody towards mannose 6-phosphate, you will find out that which are the proteins which are getting targeted. Okay, so the particular proteins which are getting targeted. So that will be having mannose 6-phosphate. Now you are putting an antibody. This antibody will be attached towards this mannose 6-phosphate. So you get create a something like a sandwich kind of thing. So the protein is here. M6P, mannose 6-phosphate is here. Your antibody is here. So this is a sandwich technique, like okay. So it will bind to here, this will bind to here. So you will find out all the proteins which are attached to this particular mannose 6-phosphate residue. Now, if there is a defect in this particular enzyme, glutamate phosphotransferase, mannose 6-phosphate cannot be tagged to the proteins. It leads to a disease called as eye cell disease or inclusion cell disease. That is also an question which is asked in the NEET examination, not in the AIIMS examination, but then glutamate phosphotransferase defect is resulting in eye cell disease. Eye cell disease comes under the category mucolipidosis, sialidosis, eye cell disease, and mucolipidosis 3. All the things come under mucolipidosis, characteristically sharing features between mucopolysaccharidosis and sphingolipidosis. Okay, something like a hybrid disease. Okay. A 3-year-old boy come for regular follow-up for the pediatric department with growth retardation, mind mental retardation with enlarged thyroid. So he is a thyroid patient, and his TSH levels are 4.5. Serum thyroglobulin levels is lesser than normal. Biopsy of thyroid reveals accumulation of thyroglobulin in rough endoplasmic reticulum. So basically, there is thyroglobulin in rough endoplasmic reticulum. Which of the following could be seen in this form? Okay. So here, basically, there is thyroglobulin which is accumulating in the rough endoplasmic reticulum. Okay. So thyroglobulin has reached rough endoplasmic reticulum, means protein targeting has happened, which means that failure to phosphorylate mannose, that is okay. So the proteins are produced in the ribosomes, and then it has reached the rough endoplasmic reticulum. Proteins targeting done. So mannose 6-phosphate attachment is not a problem here. Loss of function mutation in the DNA encoding the hydrophobic signal sequence on thyroglobulin. Loss of function mutation in the ubiquitin gene, which means that the DNA encoding the thyroglobulin itself is loss of function, means thyroglobulin will not be formed at all. But here the problem is thyroglobulin is formed, it is accumulated in the rough endoplasmic reticulum, it is not secreted to the blood. Okay, so the blood thyroglobulin levels is very low. So this is also wrong because thyroglobulin is formed, but it is not coming out of the rough endoplasmic reticulum. A TSH receptor defect and thyroglobulin monomer faulting and failure of TSH receptor defect is there, means TSH levels will not be like this. It will cause a upgraded TSH levels because it's just like a TSH is there. It is not able to bind. It will sense, body will sense it like a TSH deficiency, and pituitary will get the signals to secrete more, just like insulin resistance. This is something like TSH resistance. But here the TSH levels is near normal. So this is also ruled out. Now we are left only with one point, which is thyroglobulin monomer misfolding and failure of subunit assembly, which is very, very likely answered because the thyroglobulin is secreted into the rough endoplasmic reticulum, but then it is not assembled properly to be secreted outside the rough endoplasmic reticulum into the blood. So that is the reason why thyroglobulin gets accumulated in the rough endoplasmic reticulum and it is not secreted outside. That is the reason why thyroglobulin levels are low in the blood, whereas the TSH levels are not affected drastically because there is no problem with the pituitary, there is no problem with the thyroid gland, there is no problem with the TSH receptor levels, TSH receptors. So there is no problem in the TSH levels, but then the thyroglobulin is a problematic thing. So the answer here would be thyroglobulin monomer misfolding and failure of subunit assembly. We are halfway through. This is a repeat question. I just took up this question to teach you about this thing is in AIMS 2019 November question. Okay. This is a question where they are asking about a technique in recombinant molecular biology called as blue-white screening. Okay. Now, basically, this question is all about recombinant DNA. Recombinant DNA. See, whenever we have a DNA insert, okay, we cut a DNA insert, we load it into a vector. We load it into a vector. See, this is the DNA insert, okay? And then this goes into the host cell. And our vector goes into the host cell. Okay. Now there are two possibilities. This is the vector with the DNA piece. Okay. Now this DNA piece can get inserted or can get recombinant with the host genome, or it can be without recombinant. So, okay. So there are two phases. Recombination occurs, which means that the foreign DNA insert gets integrated with the host genome. The second is recombination does not occur. So how to find out whether the recombinant DNA has entered into the host genome or it has not entered? That is the technique where we follow the blue-white stain. In this, we have taken the lac operons. You all would have known about the lac operons. Okay. And we are going to test this with an enzyme called as beta-galactosidase. So, beta-galactosidase. We will call this as alpha peptide. We'll call this as alpha peptide. Now, the alpha peptide, okay, if the recombination has not occurred, if the recombination has not occurred, the original color of the colonies is blue. So it will lead to blue colonies. The original color of the colonies is blue colonies. But see here, this is the only alpha peptide, no recombination. Okay, it will lead to blue colony. Okay. Now, if the recombinant DNA has been introduced, which is the insert here, if they are given no lac Z58, actually it is called as lac Z58. If the recombinant DNA has attached to the host genome, then the color of the colonies will change from blue to the white. So basically, they will put a DNA insert along with the lac operons and they will incubate it. If the recombination has not occurred, then the blue colonies will come. If the recombination has occurred, then the color of the colonies will be changed from blue to white. So which means that recombination occurred means white colonies. If white colonies are there, it means that the whole genome and the new DNA insert has integrated. So that is called as a mutant. That is called as a mutant because mutant means something foreign has come and attached to the host. Okay. So mutant has occurred means the color of the colonies will become white. No recombination has occurred. The host genome has not picked up the vector DNA. It means that the color of the colonies will be blue. So this is called as blue-white screening. And this terminology of attaching the the vector DNA to the host DNA is called as alpha complementation. This is called as the alpha. Okay. So this question was asked in the AIMS examination. This is a very tough question. Nobody answered it during that time. But then if you want to answer this question, you should know that it's just simple thing. You are putting a foreign DNA into the host cell. Okay, whether the DNA is taken up or not. If the DNA is taken up, then it is white color. If the DNA is not taken up, it is blue color. Okay, that's all. It's just about recombinant DNA technology. It's a molecular batch technique, recombinant DNA technology. The other name for recombinant DNA technology is cloning. When you're reading about cloning, one of the hot topics for cloning is CRISPR-Cas9 technology. Please read about that also. Clustered, regularly interspaced, palindromic repeat sequences attached to caspase-9 enzyme. That is called as CRISPR-Cas9, and it is used for gene editing. So please read about this. I'm expecting a question on CRISPR-Cas9 any moment in INICET examinations. Okay. A 20-year-old boy's neonatal screening reveals increased levels of citric acid cycle intermediates such as succinate and fumarate. Okay, succinate increased, fumarate increased. He has been feeding poorly and failed to gain weight as expected after the accounting for respected 5 to 10% loss from birth weight. Okay, that is 5 to 10% loss is okay from birth. Okay. Repeat screening shows elevated citrate. Citrate is elevated. Alpha ketoglutarate and succinate already said. So alpha ketoglutarate is also active. So this means that all these things are elevated. Okay. So these things are elevated and these things are also elevated. Okay. Along with the venous lactate of 7.5. So lactate is also elevated. The infant is referred to metabolic medicine clinic where skin biopsy and fibroblast studies done shows deficient yield of carbon dioxide, GTP and NADPH. The key marker in this question is deficient yield of carbon dioxide, GTP and NADPH. So this means that there are only 4 enzymes which can produce metabolic equivalents of ATPs. See, there are 4 dehydrogenases in the TCA cycle. 3 of them deal with NAD plus and 1 deals with FAD plus. This one is succinate dehydrogenase. Here they have told you NAD is deficient, which means that succinate dehydrogenase is gone. It's not the answer. They also told you carbon dioxide and GTP is deficient. Carbon dioxide and GTP is deficient. Now you just have to look into the step where GTP is produced. Okay. So here it is very clear and step easily. GTP is produced in a substrate level phosphorylation reaction where succinyl CoA is converted into succinate. Okay, by an enzyme called as succinate thiokinase. Some books they give us a succinyl CoA synthetase. Okay, that is because it uses ATP to convert GTP into GTP. So here GTP is released. Now GTP yield is less means this particular step is wrong. This particular step is wrong. Where is this particular step? If you see in this picture, they are very, very clever. They have not given you succinyl CoA. Succinate CoA comes from alpha ketoglutarate. So alpha ketoglutarate succinyl CoA has happened, but then succinyl CoA to succinate has not happened. There is a block in this step. That is why there is decreased GTP. Okay, that is why there is decreased GTP. Now alpha ketoglutarate to succinyl CoA is involved in the NADA formation. So that is why there is defective NAD. There is also a carbon dioxide released here. So that is also. So overall, they have combined 2 steps together to confuse you, but then the answer will be the same. GTP yield is less means it is only step C. It is not step D, it is not here. It is not step A, it is not here. It is not B or it is not E. They are speaking about one particular step, which is step C. Okay, that is fine. So this is very concrete concept about TCA cycle. You should know TCA cycle in and out to answer this question. A 45-year-old non-diabetic female is found unconscious at her work desk. On eliciting the history, they found an insulin injection pen. Okay, so insulin overdose, hypoglycemia. So serum glucose is 30. What are the following statements? Best explains the pathology. Why insulin causes hypoglycemia? That is exactly what they are asking you. Okay. Now, you all know that I have already told that insulin, very simple. Insulin increases glucose uptake. and it increases glucose uptake in only 3 tissues. Okay, what are those? Adipose, skeletal muscle, cardiac muscle. Now you have to look for this particular option. Her liver was suddenly permeable to glucose. Liver does not have a role. Insulin does not uptake glucose into the liver. Okay. Insulin stimulated liver glucokinase, which phosphorylates glucose. No, that is also wrong. Insulin stimulated glucose uptake into her liver. See, all the 3 options has liver, liver, liver. But what about the 4th option? Her insulin increased glucose transport into extrahepatic tissues using various glucose. Very simple. And this various glucose transporters is nothing but CLUT4. Is nothing but CLUT4. Is it okay? So the answer here would be insulin increased glucose input into extrahepatic tissues via. If insulin wants to do glycolysis, insulin can opt for hexokinase. Glucokinase is present in the mainly in the liver and pancreas, but other tissues, insulin uses hexokinase. Okay, there is a whole lot of tabular column differences between hexokinase and glucokinase. I would have taught you that in the class. So do please go home and read that. Okay. Now we have got a picture. A 22-year-old man with history of sudden rectal hemorrhage. Okay. Hepatosplenomegaly present, which means that Tay-Sachs is out. And blood test disclosed thrombocytopenia. A liver biopsy demonstrated a typical cell in Gleason's capsule. I will tell you what is that cell. Finally, what diagnosed as inborn error of metabolism storage. So which of the following? See, here it is very simple. You have a cherry red spot. Okay. Now, cherry red spot is not present in Sandox. Okay. Cherry red spot is present only in 3 diseases. Niemann-Pick. Okay. Tay-Sachs, Gaucher. Okay. Now, Tay-Sachs I have eliminated because hepatosplenomegaly is present. There is only a confusion between Niemann-Pick and Gaucher. You all know that Niemann-Pick will present with regression milestones. The history will be very early age. This is a 22-year-old man, and he is presenting with thrombocytopenia. The very classic feature of Gaucher's is anemia and thrombocytopenia. And the typical cell is Gaucher cells. To be frank, it is not actually Gaucher. The disease has to be pronounced like this. This is the pronunciation for that disease, Gaucher. Okay. So this particular question is not about Niemann-Pick. It is about Gaucher. And let me be very clear. It is a very hot topic when it comes to sphingolipidosis. Gaucher's is a very hot topic for sphingolipidosis. To read about everything about that. Crumpled tissue paper appearance. Have this in mind. Crumpled tissue paper appearance is very much characteristic of Gaucher. Okay. A biochemical genetic laboratory did a study which includes 5 patients who test positive for reducing sugars. Among the 5, 2 were young females evaluated for vomiting and failure to thrive, while other 3 were a boy and 2 girls. Okay. Mass spec reveals a urine chemical with 6 carbons and ketone group. Very good. Reducing sugar, 6 carbons, ketone. These are the findings. You just have to tell me which is the component we are speaking about. Okay. Let me go ahead and eliminate one by one. Number 1. Ribulose is a 5 carbon, so it is 1. Now, remaining 3 are 6 carbon compounds, so it can be anything. Remaining 3 are all reducing sugars, it can be anything. But there is only one component among this, which is a ketone group. This ketone group is fructose. Okay. So, if you want to go ahead with the answer, the question itself is big, but then the answer will be very easy. It is fructose and fructose 1-phosphate. And this particular disease is either fructose urea or hereditary fructose intolerance. It can be a fructokinase deficiency or it can be a aldolase deficiency. both of it can be there. Most likely to be a hereditary fructose intolerance. Okay, so fructosuria is a very harmless disease, just fructose is excreted in it. Yet there is vomiting and failure to thrive, so it could be very well a aldosterone deficiency leading to hereditary fructose intolerance. This is a case of hereditary fructose intolerance. The answer is A. A 25-year-old woman with phenylketonuria gives birth to her first child. At birth, the child presents with microcephaly and elevated blood phenylalanine. What you need to know is, at birth itself, the symptom is there. Usually, in phenylketonuria, the most of the symptoms are evidenced in 4 to 5 days time after birth. And here, at birth itself, the child manifests with features. There is no history of PKU in father's family, and the couple could not afford a genetic testing of the father or consistent prenatal care. What's the most likely reason for the child symptoms? Now, the symptoms are present at birth means in utero itself, there is a exposure to phenylketonuria. In utero exposure, which means that the damage has been done during the pregnancy period itself. Now, the mother is a phenylketonuric patient. Okay, she is conceiving. So the first line of treatment for a phenylketonuric patient should be a phenylalanine restricted diet. Okay, but she has conceived, she has not got a prenatal care, and this baby has exposure to phenylalanine during the gestation period itself. That is the exact reason why it is presenting with features during birth. Okay, there is no reason for phenylalanine or phenylketonuria to be presenting with translocation or unbalanced segregation or uniparental trisomy. It is not a chromosomal disorder. It is basically a simple fact that the mother did not have a phenylalanine restricted diet during pregnancy. So that means the mother had a lot of phenylalanine. The baby also inherited the phenylketonuric genes. So the baby also had an exposure to phenylalanine. So it was toxically phenylalanine accumulation in the baby. When the baby is born, it is born with elevated phenylalanine and the features of phenylketonuria. Okay, so you need to do a screening. There is a must for phenylketonuria. In the United States, every child is screened for phenylketonuria. In our setup, we don't screen babies for inborn error of metabolic screening. But then I always advise all the babies must undergo something called as a GALAX screen. Okay, what is a GALAX screen means? It is glucose, okay, ABG, lactate, ammonia, and ketones. Okay, so every baby must undergo a GALAX screen. This will solve most of the problems because we will try and find out if there is any problem. See, inborn error of screening can cost up to north of 6,000, 7,000 rupees. Okay, but then a GALAX screen can be done in all the hospitals. Almost totally, it will come around 1,000, 2,000 rupees. All the poor patients can afford that. So I think every baby should undergo this particular GALAX screen so that the basic disorders can be segregated from the very complicated ones. Okay. Pseudogenes are homologs of functional genes that lack promoters. See, the statements are big because I want you to give information through the question also. 98% of human genome is junk. Only 2% is exons. And what is this junk means? This junk is consists of pseudogenes, introns, reverse transcriptases, all these things. And what are pseudogenes? Pseudogenes are basically homologs of functional genes that lack promoters. They do not have promoters. So when there is no promoter, there cannot be no transcription. So they are basically unexpressed. They are unexpressed DNA. So that's why they are put in the category of junk DNA. Some of the pseudogenes are produced by reverse transcription of mRNA and insertion of such resultant cDNA into a chromosome by a virus. So basically, they are under the opinion that pseudogenes are produced by reverse transcription. Reverse transcription, and what is reverse transcription? mRNA is converted into DNA. Usually, the DNA is converted into RNA, but the reverse transcriptase is conversion of mRNA into DNA. Okay. In addition to lacking a promoter and other regulatory elements, a pseudogene produced in this manner will differ from the authentic gene in which of the following ways? Pseudogene and original gene, which of the following ways it will differ? That is what they are asking. Okay. So if you are asking this particular question, you need to tell which is the difference between the pseudogenes and the original genes. Pseudogenes will contain an oncogenic mutation. No. Pseudogene will contain nested genes for antibiotic resistance. No. Pseudogenes will require chain diagram. When there is no transcription, there is no need for what to say. There is no need for translation. Chain diagram sequence is a component which is involved, which is present in the ribosomes, where the mRNA tunnels into the threads into the ribosome. So when there is no transcription, there is no need for chain diagram sequence. Now, pseudogenes has only introns, whereas original gene, authentic gene, has exons and it does not has introns. So the correct answer here is the original gene lacks introns, whereas the pseudogenes has introns. Okay. So pseudogenes basically they are unexpressed, which means that they have rich introns, whereas the original gene are expressed regions. That's exactly why they call exons. So pseudogenes have introns and the original genes have exons. Here they are asking about the authentic gene. Authentic gene will have exons. So that is the correct answer when it comes to this particular issue. A male patient came to the clinic complaining of lack of energy and abdominal pain, and he had a hepatosplenomegaly, also bronze discoloration of the skin. An iron panel says serum ferritin, TABC, and serum iron are all done. The iron blood test came back with results over 45% serum transferrin saturation and elevated serum ferritin level. So this is a very clear-cut case of iron overload or hemochromatosis. Okay, so transferrin is saturated heavily, ferritin is very high. Okay, so which of the following is true? They are just asking. Okay, in this case, we will go one by one, option one by one. Okay, I'm just see here. The mRNA for transferrin receptor is bound by iron regulatory proteins and is degraded. One of the options is this, so I'll just go to that particular question. Question number 31, right? Okay. So the mRNA for the transferrin receptor is not bound by iron regulatory proteins and is degraded. Okay. Basically, transferrin receptor mRNA is degraded. That is because in hemochromatosis, what happens is more and more transferrin receptors is that more and more transferrin will get binding to it. So the body says whenever there is an iron overload, okay, the transferrin saturation will be complete. So the excess transferrin receptors must be degraded. Okay, the iron regulatory proteins, there are so many iron regulatory proteins, cis iron regulatory proteins, trans iron acting responsive elements, all those things. So when there is transferrin is fully saturated, transferrin receptors will get degraded because there is no need for transferrin receptors to be alive. So statement A is correct. The second one, the mRNA of apoferritin is not bound by unregulatory proteins and is translated. Now, whenever there is more and more iron, all the iron has to be converted into ferritin. Okay, apoferritin is a precursor for ferritin. So, more iron means more ferritin must be formed. More ferritin means more apoferritin must be formed. So, in order for apoferritin, which is a protein, here, iron overload leads to more ferritin formation, which is more apoferritin. Statement B is correct. Iron overload will saturate all the transferrin, so there is no more receptors which are required for transferrin to be bound, which means that transferrin as such receptors will be degraded. So if you see here, option A is correct, option B is correct. What about the third one? The mRNA for transferrin receptor is stabilized by the iron binding proteins. No, mRNA for transferrin receptors is not stabilized. Rather, the mRNA is degraded because we don't need transferrin receptor. many oxygens are saturated, it is loaded. Okay, fully bound and it's fully loaded. So option C is wrong. So the last option, both A and B will be correct, is the correct answer here. Okay. So that particular option is missing here. Here the correct option is both A. Okay, that is correct. Fine. A 45-year-old woman who is of height 155 centimeter and weight 85 kg. She is clearly obese. Okay, and measured 42 inches waist, 42, and hip 38. Okay, and she comes to the doctor. She is overweight. Her child, sister, parents all are overweight. Past history of overweight throughout the course of childhood and others. She was on dietary restriction, discontinuation of which causes her weight gain. Which of the following best describes? Now, whenever there is a waist and hip ratio given, you should get a waist hip ratio measurement. See, the waist hip ratio of this particular patient is 1.10. Okay. Now, in obesity, there will be two types. One is apple type, the other one is pear type. Okay. So this apple type is a male type obesity. Pear is a female type obesity. Okay. So you just see the shape of apple and pear. Now, whenever the waist hip ratio is greater than 0.8 for females and greater than 1 for males, it comes under apple type. See this particular woman's ratio, her waist to hip ratio is 1.10. She is clearly coming under the apple type obesity, and apple type obesity is characteristic for males. Okay, now she is getting an obesity which is under the characteristic feature of males. Actually, let us see the options. Again, the options are cut out. Okay, so we'll see the options. What are the options? Number one, she has approximately the same number of adipocytes as an individual of normal weight, but each adipocyte is larger. They are discussing about adipocyte hypertrophy, but you must remember that in obesity, there will be adipocyte hypertrophy. There also will be adipocyte hyperplasia. The number of adipocytes will be more. So the option is wrong because they are saying that normal person same adipocytes will be there. No, adipocyte number will be more. Adipocyte size will be more. Leave the second option. Third option, she will be expected to show higher than normal levels of adiponectin and lower than normal levels of circulating leptin. Always remember, the more the leptin concentrations will be directly proportional to the fat mass. If there is more fat, more leptin. Okay, this particular woman has a lot of fat. She is coming under male type of obesity, that she will have a lot of adipocyte mass, which means that adipocyte released leptin will be very, very high. This particular option says that low levels of leptin. That is also wrong. Option A is wrong. Option C is wrong. Come to the fourth option. She is expected to show lower than normal levels of TG. Very, very wrong. Triglycerides will be very high. She is already overweight, so that is also wrong. This is the correct answer. She shows an apple pattern of fat distribution, which is characteristic of males. So that means the option number 2, option number B is correct answer. Okay, so this particular option B is a correct answer. You must be very clear. This may be a particularly new concept to you, but today you just learned this apple type obesity and pear type obesity. A 2-year-old child presented with history of progressive asymmetrical limb girdle weakness, which means that there is a muscle weakness. Okay, with failure to thrive and gain weight. On examination, abdominal distension with hepatomegaly is seen. A muscle biopsy revealed vascular myopathy and a liver biopsy showed hepatocytes loaded with minimally branched glycogen. That is a classic feature. Minimally branched glycogen. So the glycogen is there, but it is not branched. It is not in its adequate structure. Minimally branched. There is not many branches. So very less branches. Very less branches means there could be only one reason. That is an enzyme called as branching enzyme. Branching enzyme defect. Branching enzyme defect. Now, branching enzyme defect is Anderson's disease or type 4 glycogen storage disorder. Okay, so you should know about the various glycogen storage disorders. It's very, very important. The most important would be the first one, or the von Gerke disease. Von Gerke disease. Okay. I'm not going into much details. Von Gerke disease has doll-like phases, okay, that you should remember. And then it has fasting hypoglycemia, hyperuricemia, lactic acidosis, ketosis, gout, and also there is a glucose 6-phosphatase defect. But then in NEET 2023, they asked one question about type 0 glycogen storage disorder, that is glycogen synthase defect. Usually I don't teach that, but then they ask this particular question, which is in the particular case history, there was no glycogen formed at all. So which is a defect? That is type 0 or glycogen synthase defect. Now, which are the glycogen storage disorders which presents with liver involvement? 1, 3, 4, 6. All this present with liver involvement. Which of the following presents with muscle? 5 and 7 presents with muscle. That will classically 5 is McArdle's disease, M for M, muscles. Okay. There is one particular glycogen storage disorder which presents with heart involvement, that is glycogen storage disorder number 2, which is always called as Pompey's disease. Okay. So all this you should remember. Do please read about glycogen storage disorders. Very, very, very important. A 34-year-old individual who has been recently diagnosed with dyslipidemia is prescribed a drug atorvastatin. Okay, he is advised to limit the consumption of grape juice because high intake of the juice seems to result in an increased level of drug in the blood, thereby increasing the risk of side effects. Atorvastatin is an efficient substrate for cytochrome P450 CYP3A4, and consumption of grape juice inhibits the enzyme. This itself is an MCQ. Grape juice should not be taken by the people who are taking atorvastatin. Which statement is correct regarding P450? Now they are not asking you about atorvastatin, they are asking you about P450, cytochrome P450. Now the word 450 refers to 450 nanometers, and P for pigment. It is yellow in color, cytochrome. In cytochrome, there is an yellow pigment protein which is absorbing maximum light at 450 nanometers. That is why it's called as cytochrome P450. Okay. So which is true about cytochrome P450? Now there is few things we should know about cytochrome P450. P450 gets its electrons from NADPH. Point number 1. And the electrons are transferred to cytochrome P450 reductase. That is the enzyme which receives. Okay, electrons, no? Reduction, electrons. Okay. And then cytochrome P450 is a hemoprotein. It contains heme. There are many other hemoproteins. Cytochrome P450 is a hemoprotein. Now, if you come to this particular options, they accept electrons from NADH. No, wrong. It is NADPH. They function in association with an oxidase. No, it is a function with reductase. They differ from nitric oxide synthase in that they contain heme. They contain heme. Nitric oxide synthase also contains heme. So that is also wrong. Okay, there is no difference. Both of them are hemoproteins. They catalyze the hydroxylation of hydrophobic molecules. It's a correct answer. So this is a particularly correct answer. They basically cause hydroxylation and hydroxylation of hydrophobic molecules. They get the hydroxyl groups from the hydrophilic molecules and they hydroxylate the hydrophobic molecules. So this answer is option D, which is the correct answer. A 40-year-old man is diagnosed with cancer of proximal colon. History of cancer in the family. His father died of colon cancer at the age of 58. His 55-year-old brother has not been diagnosed with cancer, but 56-year-old sister has an endometrial carcinoma. And his other sister died of ovarian cancer. So this runs in the family. Okay, it's a familial cancer. Okay. And the diagnosis of HNPCC is made. Which of the following mutations would have most likely occurred in this family? Is not only HNPCC, it is also a history of something called as Lynch syndrome. See his sisters. His sisters died of endometrial carcinoma. ovarian carcinoma. And you all know that HNPCC is caused by defective mismatch repair. See the first option, point mutation in the gene coding for excision endonuclease. That would be nucleotide excision repair. That is because of in the diseases in xeroderma pigmentosa. The third option is retinoblastoma tumor suppressant. That is loss of function mutation. Okay, like in P53, RB tumor suppressant retinoblastoma. Okay, translocation is Burkitt's lymphoma. So all these are particular diseases. The correct answer would be mismatch repair system. Do read about all the diseases that come under nucleotide excision repair. Xeroderma pigmentosum, cocaine syndrome. Okay, all this is. And the mismatch repair is HNPCC. Base excision repair is MUTH associated polyposis. Okay, and then homologous recombination defect, homologous recombination, trichothiodystrophy, tiger trailing pattern. That is on MCQ. Okay, and then spinocerebellar ataxia. That is also homologous recombination. There is one MCQ. Sickle cell anemia comes under which DNA defective repair mechanism? Non-homologous recombination. So all these are to be remembered. Okay, and double strand repair mechanism defect. Bloom syndrome, DNA helicase defect. That also you should remember. All these are 6 or 7 MCQs that is coming from Harper. What is that? DNA repair mechanism. What table is there? One blue color table, violet color table will be there. Please do read about that. That will be very, very important for you. The initial plug formation, this is not exactly a biochemistry question, but then I thought you should know. So I just put up this question. The initial plug formation at site of vessel injury follows adhesion, activation, and aggregation of platelets. Step 1, adhesion of platelets. Step 2, activation. Step 3, aggregation. Which of the following statement is correct about the formation of platelet plug? Just remember, these are platelets. Okay, these platelets have a receptor, and then there is a binding of something. See, platelets have a receptor called as glycoprotein. Okay, and one Willebrand factor comes and binds to this particular receptor, and then which is attached to platelets. Now, this whenever there is an injury, there is exposed collagen in that site, and then the platelets are expressed. Platelets are moved. So that is adhesion. And then when the one Willebrand factor binds to glycoprotein 1B, it is called as activation. And then the platelets start coming together one by one and gets formed into a platelet plug. That is called as the aggregation. So these are the 3 steps when it comes to platelet plug formation when there is an injury. Okay. Number 1, activated platelets undergo a shape change that decreases the surface area. See, activated platelets do undergo a shape change. They are converted from a discoidal shape to a spherical shape, but then that does not decrease the surface area. It rather increases the surface area. So this option is wrong. Okay. Formation of platelet plug is prevented in intact vessels by the production of thromboxane A2 by endothelial cell. Formation of platelet plug is not prevented. It is enhanced. Okay. By the production of thromboxane A2. In fact, thromboxane A2 causes platelet aggregation. Thromboxane. Okay. It's a form from the prostaglandin pathway. So it causes platelet plug. Okay. The activation phase requires production of cyclic adenosine monophosphate. No, it does not require CAMP. Rather, it requires GDP. This is what is needed for the activation phase. So this is also wrong. We just look at the third option. The adhesion phase is mediated by the binding of platelets to 1 Willebrand factor via GP only. That is exactly what I taught you here. So the correct answer for this question would be option C. Okay, so I told you why the other 3 options are wrong. So basically the activation requires GDP. Okay, does not require CAMP, and then it is increased surface area, and it is actually thromboxane A2 causes platelet plug formation. Central dogma defines DNA is transcribed into RNA, which is then subsequently translated proteins. A is a right statement. Just go ahead. Okay. Just go ahead. Okay. We will take off whichever is telling A is wrong. This option is wrong. Okay. Fine. Retrovirus shows reverse transcriptase activity of central dogma, where RNA is first converted to DNA, which is transcribed to RNA, which is finally translated into proteins. Okay, so what is here is retrovirus is showing reverse transcriptase activity. Correct, that is correct. Basically, reverse transcriptase is a RNA dependent DNA polymerase. RNA dependent DNA polymerase, which means that RNA is there. From that RNA, DNA is converted, and this DNA is further undergoes a replication. So this is also correct. So both assertion and reason are independently true, but the reason is not the correct explanation for assertion. Both assertion and reason are independently true, and the reason is the correct explanation for assertion. So this here, both are correct, and then they also say reverse transcriptase activity of central dogma, which means that this is also correct. So the correct answer here would be both A and R are independently true, and the reason is a correct explanation for the assertion. Okay. A woman brings her 15-year-old daughter to a physician because she has not yet attained menarche. Though her parents are of normal height, not attained menarche. Okay. The patient is always below the 50. Growth retardation is there. So no menarche, growth retardation is there. Physical examination shows no breast development. No breast development means no secondary sexual characters. Everything is going towards one particular diagnosis. Okay, what is the underlying basis for her conditions? Now see, balanced translocations will not cause this much alterations in the phenotype. So phenotypic alterations is very minimal. So which means that we can take both the options. Both of them are wrong. Okay, and she is telling that there is no menarche. Okay, but she is a female. She has not got menarche. Okay, and this female secondary sexual characteristics also is there. So there is some problem with the X chromosome. There is some problem with the X chromosome, which is the disease which has problem with X chromosome. It is 45XO or the Turner syndrome. It's a Turner syndrome. So they have something called as streak gonads. The ovaries are not much developed, so there is no hormones, so there is no secondary sexual characteristics, or that thing can be there. And X chromosomes always present with bar bodies. So two bar bodies will be present with 47XXY or something like this. It is not present with. So these are people with enhanced female characteristics. Okay, that is where you get the bar bodies. Okay, this is a girl without female characteristics. So there is a missing X chromosome. So that is something like a Turner syndrome. That is exactly why the answer is like that. Question number 40. Piercinin and rotenone are inhibitors of electron transport chain. That is correct. And piercinin and rotenone are inhibitors of complex 1 electron transport chain. So the second is piercinin and rotenone inhibits the flow of electron between complex 2. This is wrong. Which means that reasoning is wrong. We will just see. A and R both are right. A as well as R are right. Wrong. A and R both are wrong. A is a right statement, but R is not a correct explanation of statement. Okay, so you just have to know about the complex 1 inhibitors, complex 2 inhibitors, complex 3 inhibitors, complex 4 inhibitors, uncouplers, ADP translocase inhibitors, ATP synthase inhibitors. All these things you need to go know about that. Please do read about that. And complex 1, okay, piercinin, rotenone. Complex 2, succinate, succinate, carboxyl, TTFA. Complex 3, BAL and antimycin A. Complex 4, hydrogen sulfide, carbon monoxide, cyanide. ADP translocase inhibitor, atractyloside. ATP synthase inhibitor, oligomycin. Uncouplers, 2,4-dinitroprazole, 2,4-dinitrophenol, thermogenin, brown adipose tissue. And then This is exactly what you should know, and please do learn about all these things. Do not forget. Please do have it in your mind. Don't make a mistake in this. A scientific team used depoform TM technology, a nano drug delivery system. So they are speaking about new drug delivery systems, NDDS, pharmacology. In treating a 90-year-old boy with extensive repeated episodes of fungal infections, and drug delivery system, everything is very clear. The drug delivery system seeks to alter the biodistribution profile of the drug, thereby enhancing the therapeutic index, increases the therapeutic index, more bioavailability of the drug. Which of the following drug delivery system is employed here? Everybody will know that it is liposomes. You all know about already another drug which is used for fungal infection, liposomal amphotericin B, which was used in mucormycosis, fungal infections. Okay. So liposomes are enhanced drug delivery systems where the drugs are packed inside lipid layers. Okay. Lipid bilayers, basically, they are used in surfactants. Okay. And then micelles are used for lipid digestion. Aquosomes are used for delivering of peptides like insulin and all those things. Okay. For lipid drugs, we use liposomes. Okay. The liposomes are prepared by sonicating the lipids. Okay. Sonicating means sound induced vibrations. Okay. The lipids arrange itself like this in two layers. Okay. So here we load the drugs and then we send it across, it gets absorbed. Okay. So the answer here is liposomes. A 48-year-old male's complaints of pain and tingling in fingers and blood division since 10 days. He developed sudden episodes of incoordination and slurred speech. His wife gave history of depression and argumentative speech. He was finally diagnosed with multiple sclerosis with optic neuritis. Okay. So you know that multiple sclerosis is a demyelinating disease, which means that option A is gone, option B is. Okay. And multiple sclerosis basically is a demyelinating disease, demyelinating, which means what? Myelin sheath is disturbed. And myelin sheath comes from a particular sphingolipid called as sphingomyelin. So basically, you should look for options which say that sphingolipids from brain and spinal cord are not there. Okay, loss of sphingolipids. Okay, and phospholipids is also lost because a lot of phospholipids is, you know about the phospholipids, right? Lecithin, choline, kephalin, all those things are also phospholipids. Okay, so the correct answer here would be it is a demyelinating disease and it is associated with loss of phospholipids and sphingolipids. That would basically is a sphingomyelin. Okay, sphingomyelin. So there's a lot of antibodies, monoclonal antibodies, which are available for treatment for multiple sclerosis. So you can take the multiple sclerotic injections, and loss of myelin sheath will cause secondary manifestations for this particular disease issues. A 45-year-old male with sedentary lifestyle came with complaints of abdominal pain. On examination, the characteristic clinical feature is given. His abdomen ultrasound reveals hepatomegaly. Blood samples collected for lipid profile appears as a creamy layer. This is clue number 1. Over clear plasma and 24 hours of collection, and the result shows elevated TG and cholesterol levels. This is clue number 2. What could be the diagnosis? Now see, the most common tendency of the students to look at this kind of pictures is to go for hypercholesterolemia, familial hypercholesterolemia, or type 2 hyperlipoproteinemia disease, which is called as the Fredrickson classification, type 2 hyperlipoproteinemia, or familial hypercholesterolemia, because they are so obsessed over this LDL receptor defect, ApoB increased production defect, that they are always thinking that every question is asked from that particular area. But here, there is 2 differences. Number 1, these are xanthomas, but then these xanthomas are called as eruptive xanthomas. Now, the xanthomas which you get in the hypercholesterolemia are called as tendon xanthomas developing in the Achilles tendon. And arcus senilis history will be there in the eyes. Okay, xanthulus mass. Okay, pancreatitis. All these things histories will be there. But here you have eruptive xanthomas. Number 2, there is elevated triglyceride. Number 3, creamy layer in the plasma. All these point towards increased chylomicrons. So we are basically talking about familial hyperchylomicronemia. So this is basically hypercolor. There is also an option here, C, familial hypercholesterolemia. This is the wrong answer. We are speaking about familial hypercholesterolemia. Just remember these 3 points. Type 1, familiar hyperchylomicronemia, eruptive. Type 2, familiar hypercholesterolemia, tendon xanthomas. A beta lipoproteinemia, there is no cholesterol. Okay, there is no cholesterol. In broad beta disease are the type 3 hyperlipoproteinemia. It is also called as a remnant disease. You get Palmer xanthomas. Okay, Palmer xanthomas. Okay, so just remember this. A beta lipoproteinemia, you won't even have triglycerides and cholesterol. So that is straight away ruled out. Okay, so here the answer is type 1. That is due to lipoprotein lipase defect. That's due to lipoprotein lipase defect. Is it okay? Fine. Good. A 65-year-old man presents with complaint of recent onset difficulty in performing daily activities. Exaggerated kyphosis with abnormal walking and gait, which is slow on wide base. He also has resting tremor. The appropriate management which would target which of the following. It's a very classic history. Okay. Difficulty in performing daily activities. Point number 1. Abnormal walking and gait. Point number 2. Slow and wide base gait. Resting tremors. Point. All these things point towards one disease, which is Parkinson's. This is called as bradykinesia. Okay, bradykinesia, resting tremors, gait. Okay, and the finger rolling movements, mask-like faces. Basically, the problem is there is something in the brain called as substantia nigra. This substantia nigra is involved in catecholamine synthesis. Catecholamines basically is dopamine, epinephrine, norepinephrine. Okay, these are basically special products from amino acid tyrosine. Okay, so the loss of substantia nigra means loss of catecholamines. Loss of catecholamines means loss of dopamine. All these particular symptoms. So any kind of management would be targeted towards enhancing catecholamine synthesis or enhancing dopamine availability here. So the answer here would be catecholamine synthesis because it's a classical history of Parkinson's disease. A 36-year-old male presented to the physician with extreme fatigue, arthralgia, and loss of libido. This detailed history taking classic triad of bronze diabetes is noticed, and the total iron body iron content is 36 grams, which is 5 times greater than the normal value. He is also a known alcoholic. So what could be the triad of bronze diabetes? So basically they are asking you what is the triad of bronze diabetes. Bronze diabetes is another name for hemochromatosis. Okay, 3 organs are affected: liver, pancreas, skin. In skin, hemosiderin deposition leads to the brown color. Okay, and in pancreas, the cells producing insulin are dead, so it leads to diabetes. In liver, the same hemosiderin leads to hepatomegaly, and finally cirrhosis. So cirrhosis, diabetes, and hemochromatosis. This will be the correct answer. Okay, so there is no heart involvement. There is no hepatocellular carcinoma. There is no arthralgia. Okay, so basically that is cirrhosis, hemochromatosis, and diabetes. So these are the form the triad. Okay, chroma. See the name chroma, color. Okay, hemochromatosis. Okay, the answer would be option A. A 4-year-old child was brought to the emergency room with complaints of muscle pain and weakness after playing. Okay, while playing, excitement is there, increase in noradrenaline, and increase noradrenaline, mobilization of fatty acids and glycogen to release energy. Okay, so all this must happen to release energy. Okay, but this child complained of muscle pain and weakness. So there could be 2 problems. It's either glycogen breakdown problem or it is fatty acid mobilization or fatty acid breakdown problem. Okay, somewhere or the other the energy is not released. So a liver biopsy He also had hepatomegaly and cardiomegaly. A liver biopsy was done, which shows non-specific fatty changes. So this is not a glycogen problem. This is a fatty acid. So basically, it's a fatty acid disorder. Muscle biopsy shows large number of cytoplasmic vascules containing neutral lipid, which means that lipids are not getting broken down. Okay. A one-day fast test performed shows a drop in blood glucose levels without corresponding production of ketone bodies. Okay. So why ketone bodies is not produced means even when you are fasting, okay. So this is a very classic feature to tell you that this particular baby is not suffering from ketone bodies means there is no glycogen disorder. Or in particular, they are telling that this baby is not a von Gilkis because I told you in von Gilkis disease there will be ketosis, fasting hypoglycemia. So the basic, see the problem here is you need to differentiate between the glycogen storage disorder and the fatty acid. They are giving you ample clues to differentiate that. Number one, they told you there is lipid accumulation. Number two, they are telling you there is no ketosis because this is to tell you that this is not a glycogen problem. You are looking at something which is related to a fatty acid problem. Okay. So what is your particular diagnosis? During this, pH of the blood is normal. This is another pointer. See, in von Gilkis, there will be lactic acidosis. I told you lactic acidosis, which means that the pH will drop. So they are telling you again and again, this is not a von Gilkis. Do not confuse von Gilkis. Do not confuse with McArdle's disease. Nothing is there. There is no problem with glycogen. The problem is with fatty acid. See, these are two more options. No need to worry about bilirubin or vitamin D. We have ruled out von Gilkis. The only option is carnitine deficiency. Carnitine is not there, means fatty acids cannot enter into the mitochondria. Carnitine is a transporter of large fatty acids, correct? Large chain fatty acids. So when there is a carnitine deficiency, the fatty acids cannot enter into the mitochondria. It means they cannot broken down by the mitochondria. Beta oxidation of fatty acids cannot happen. So the ATPs are not released. When there is no ATPs, there is no gluconeogenesis. The baby is going to hypoglycemia. So the correct answer here would be carnitine deficiency. Carnitine deficiency also presents with hepatomegaly, cardiomegaly also. Okay, very classic question. And a 88-month-old boy brought to his parents for progressively lethargic and pale. Okay, he has anemia. Okay, the child has normal urea, low iron, hemoglobin is 4.2. Okay, leukopenia, bone marrow analysis, megaloblastosis. So this is a megaloblastic anemia. The child was treated with iron, folic acid, vitamin B12 or pyridoxine, but fails to respond. Very classic. I told you. See, there are mainly three causes for megaloblastic anemia. Vitamin B12, folic acid, orotic aciduria. Okay. Now, if there is megaloblastic anemia because of vitamin B12 or folic acid, it will respond to treatment. There is only one megaloblastic anemia which does not respond to treatment with vitamin B12 or folic acid. They are just asking you which of the following pathways is found to be defective. The question is again cut, so I go to the which of the following pathways are found to be defective in this child? Homocysteine metabolism. There is no role for homocysteine metabolism. The disorders associated with homocysteine metabolism are homocystinuria, cystinosis, cystathionuria. Okay, and of course, cystinuria. Nothing is there. Purine synthesis. In purine synthesis, the disorders associated are severe combined immunodeficiency disorder, Lesch-Nyhan syndrome, gout. No problem. Uric acid synthesis again is same as purine synthesis. So option this is wrong. Option B and option D both are same. We'll rule out that. Homocysteine metabolism also is ruled out. Pyrimidine synthesis. Yeah. Pyrimidine synthesis is very important. Option C. That is because only in pyrimidine synthesis you get orotic acid. So here the diagnosis is orotic aciduria. They are just basically asking you orotic aciduria is which fatty disorder? That is pyrimidine synthesis. So the correct answer here is option C. Okay, option C. You must know two things. Number one, orotic aciduria is refractory anemia. Number two, orotic aciduria is part of pyrimidine synthesis pathway. If you know this, then you will crack this particular question. See, always I used to tell to my students, if you do not know any answer, do two things. One, pray to God. You remember what is there. Number two, just leave that question and go to the end of the paper. You read all the questions through the paper. Okay, there is high chances one of the other question might give you a clue which can help you remember answer to that particular question. Okay, so if you had come to this question, you could have, you know what, synced your thoughts. You could have answered that question as well. You could have answered which question? The urea cycle disorder. Okay, ornithine transcarbamylase deficiency leading to high uric acid, and then orotic aciduria also not responding to treatment to vitamin B12 and folic acid. So this kind of help you will get. Uh, so that is, you must have patience. You must have the tenacity to go through the paper, and you must have the eyes to pick up the clues and minds to process the clues. Okay, so that is not a easy job. It will come only by practice. Okay, please do have this in mind. Okay, option number 48. So question number 48, methotrexate competitively inhibits folate reductase due to its structural similarity to folic acid. Cancer cells develop resistance if the drug is taken for a long time, which is correct. A is correct. Okay, which means option D is wrong. A and R both are wrong. Okay, we'll just go ahead and read the second statement. Drug resistance is by genes we change. Now, drug resistance is a component which is because of a phenomenon called as gene amplification. If you have attended my class, I would have taught 6 modifications in the post-transcriptional modifications. One of them being gene switching, gene rearrangement, RNA editing, alternate splicing, gene amplification, and splicing. Okay, normal splicing. Among these, gene amplification is associated with drug resistance. It confers drug resistance. So, reasoning is wrong, assertion is correct. So, we just have to find out which is the option here. A and R both are right, but R is not the correct explanation of wrong. R is not a right side. A as well as R are right. This is also wrong. A is right, but R is a wrong state. That is the correct answer. Option B will be the correct answer. Okay. Okay. A 58-year-old man presents with history of severe low backache, loss of weight and appetite, and exertional fatigue. No significant past medical history. Serum electrophoresis revealed an abnormal band between beta and gamma regions. X-ray shows occult lytic lesions and is given. From the above findings, conclusion of malignancy was made and patient has. Very straightforward question. One of the very easy questions is a question of multiple myeloma. They have told you that there is a band, M band is present in the beta gamma region. See, beta gamma fusion is another characteristic. Do not confuse that is present in the cirrhosis liver. Here there is very clear band. They have given you lytic lesions in the skull. They are giving you low backache. The problem now is multiple myeloma is established. Now you need to find out what type of cancer is multiple myeloma. Very simple, cancer of plasma cells. There are antibodies directed against the bone. Okay, possible. I'm just putting it very simply. So you have someone targeting your own bones. Okay, so the bones are getting resolved. That is the reason why you have lytic lesions. You can see the lytic lesions marked in the skulls. Okay, excavations, bone resorptions. The last question. A 3-month-old baby develops excessive irritability, abnormal posturing since birth, and delayed milestones. Looks like some inborn error of metabolism. History of sibling death at 10. Previous baby has died at day 10. The clinician noticed abnormal urine order, and the laboratory analysis revealed ketonuria and metabolic acidosis. Okay, so there is some particular order in the urine. HPLC analysis of amino acids showed elevated branched chain amino acids. Very simple now. This is a case of MSUD, maple syrup urine disorder. So what kind of an order is there? Burnt sugar smell. Burnt sugar smell. Okay. And this burnt sugar smell is because of a component called as sotalol. Because of component called as sotalol. Okay. Accumulated branched chain amino acids. Okay. So which of the following is not formed from branched chain amino acids? You should know what are the branched chain amino acids. Valine, leucine, isoleucine. Now, if you see, it's very, very typical. Valine is a glucogenic amino acid. Isoleucine is glucogenic plus ketogenic. But leucine is purely ketogenic. Now, whatever is meant by purely ketogenic means it produces acetyl-CoA. Okay, so wherever there is acetyl-CoA, that is coming from branched chain amino acid, which means that this option is gone, this option is gone. Okay, we are left only with two options: xanthurinate and tiglyl-CoA. Tiglyl-CoA is one of the components of valine metabolism. Okay, so it is very difficult. Do not worry about that. But you should know that xanthurinate or xanthurinic acid does not come from branched chain amino acid. It comes from tryptophan metabolism. Okay, xanthurinic acid is a marker, in fact, for tryptophan metabolism disorders. Okay, so the basic uh, uh, products in which is in tryptophan metabolism is xanthurinic acid. Okay, so the answer here would be xanthurinic acid. It is not formed from branched chain amino acids. Branched chain amino acids gives rise to acetyl-CoA, acetyl-CoA, succinyl-CoA, tiglyl-CoA, all this complex. It does not give rise to xanthurinic acid. So with this, I have completed all the 50 questions. I hope you all have a nice time with us, right? And thank you so much for staying with us, and thank you so much for learning biochemistry. I wish you all the very best for the upcoming INICET examination, and I hope you all land seats of your choice. God bless you. Thank you. Thank you. Bye. Is there any doubts? Please put it on the comment box. I will be available for the next 3 minutes. If you have no doubts, you can log out. I will share the format. I will share the uh, written PDF, and you will get it on your mail. Okay. Thank you. Thank you. Then have a good night. Bye.